Good morning, everyone, and welcome to our first brunch event in our Healthcare Maintenance in IBD series. This series is supported by educational grants from Janssen, Pfizer, and Takeda. I'm Dr. Aline Charabaty. I'm the Assistant Clinical Director of the GI Division at Johns Hopkins School of Medicine and the Clinical Director of the IBD Center at Johns Hopkins Sibley Memorial Hospital in Washington, D.C., and the founder of Monday Night IBD. I'm joined today by my good friend and colleague, Dr. Meena Bewtra. Dr. Bewtra is an assistant professor of medicine and epidemiology at the University of Pennsylvania School of Medicine and the Department of Biostatistics, Epidemiology, and Informatics at the University of Pennsylvania. Meena, thank you so much for joining me today.
I am thrilled. Thank you so much. Very honored to be invited.
Well, I'm a big fan. I think I met you first on GI Twitter, and I always loved how you advocate for your patients, for vaccinations. So I always learn from you when I log in on Twitter, and I thought, why not share this with everyone, our friends?
I appreciate it. And I have to make a very big disclaimer here that, in addition to being an epidemiologist, I am actually married to an infectious disease doctor. So I think I'm obliged to advocate for vaccines at every possible opportunity.
So we're covered today. You have
exactly.
everywhere. All right. So before we start, these are our faculty disclosure that you see on our screen, but we really wanted to focus today on what are the best practices in terms of vaccinations for patients with IBD, and really talk also about the hot topic, unfortunately, of the last couple of years and more years to come, which is COVID-19 vaccinations for our patients with IBD. So Meena, before we start all this, who is responsible for making vaccine recommendations in patients with IBD? Most gastroenterologists went into GI because they want to focus practice, but often as a clinician taking care of patients with IBD, we're confronted with this. Who makes these decisions? Who should be responsible for that? The gastroenterologist or the primary care physician?
So this is a real problem. I mean, and there's actually been studies that have shown that anywhere between 14% to only 50% of GIs think that they actually even take a vaccination history. And the vast majority, over 75% of GIs, think that vaccinations should be the responsibility of their primary cares. And for some people, like our practice, we don't even have the ability to give vaccinations in our clinic. So even if we wanted to, we couldn't do it. However, these same studies find that the majority of primary care physicians don't feel comfortable making vaccination recommendations for IBD patients, and that makes sense. They cannot keep up to date with all of the recommendations and the changes, especially with the new medications we have. All of this, though, becomes this horrible situation for the patient. And there have been very disturbing studies that less than a third of our IBD patients are vaccinated against simple things like the flu, pneumonia, hepatitis B, important vaccines. So we really have to do a better job about this. And in my clinic, again, we don't have the ability to give vaccines. So what I will do is I'll make a point of having the last section of my recommendations be general health maintenance and a section of that being vaccines. And I will include all the vaccination recommendations. The patient gets a copy of that letter sent to the primary care so that, and at every visit we follow up and say, okay, did you get this? Did you get this? So that it's always there. It's always top of mind. This is what we have to do. We have to be better at communicating, not just with the primaries, but with the patients, because they are, the go-between here. And it's really their health that we're trying to protect.
Absolutely, I agree. And I think you and I practice in a very similar way. I cannot give vaccine, but I educate patients. I put in my note, I send it to primary care doctors. And hopefully with this communication, everybody becomes more familiar and in tune to what's need to be done for our patients with IBD. And I recheck every time. So I journalist in me at every visit, which I think is very important. So as a general rule, like guidelines about vaccinations, we recommend that all our patients with IBD receive all age-appropriate vaccinations. Live virus vaccine are not recommended if you are on immunosuppressive therapy, such as immunomodulator, like azathioprine, 6-MP, small molecules, and biologic. But what kind of exception do we have to that? With vedolizumab being more gut specific, can patients on vedolizumab receive live virus vaccine if they need to?
That's a really important question. And I think it's fair to point out that there are relatively fewer live virus vaccines that we have now. And they really are yellow fever, MMR, varicella, and rotavirus. And then the intranasal influenza vaccine, which I don't recommend for any of my patients anyway. Given the gut selectivity of vedolizumab, it appears like it's probably safe to give these live virus vaccines if you need it. And in fact, some international IBD and GI associations and societies classify vedolizumab with our mesalamine products in terms of safety with our live vaccines. So, if you need to, I think that's one of the biologic medications that we could feel pretty safe if we needed to give a live virus. But you're absolutely correct. For the remainder of these, you want to wait a period of time before you start the medication, or after you've stopped the medication, before you're going to expose them.
The most common infections with our patients with IBD who are on immunosuppressive therapy are really the pneumonia, upper respiratory infection, and these are the most preventable ones, right? And while we keep talking about the flu shot and the pneumococcal vaccine, and everybody should be vaccinated at this point. So tell me about your frustration and what you recommend.
So first of all, the flu. This is a dead vaccine. It can be given to everyone, and everyone 6 months and older needs to get their flu vaccine. And if there was ever a time when it was really important, I think with COVID, it's even more important, because we have studies from 2020 that show that patients who get COVID and the flu at the same time have over twice as high mortality rate. And so this is an easy get. This is low-hanging fruit. This is what everyone should be getting their flu vaccine. But the ones I think we forget about, a lot of our patients forget about, are pneumonia as well. And I think primary cares do a really good job, because this is pretty standard for the Pneumovax 23. This is something that I think everyone's a little bit more familiar with, but we want to remember that the majority of our IBD patients are going to end up on some type of immunosuppressive medication, and therefore they need to get the Prevnar 13 as well. And timing matters here. If you get the 13, you'll have to wait 8 weeks or more before you can get the 23. But if you get the 23 first, you have to wait a full year before you can get the 13. So it's easy to forget. So I always tell my patients, I'm like, aim for the low number first, get that one out of the way, and then we'll move on to the 23. But this is one that people overlook. They might remember the flu shot, but they're not thinking about pneumonia. And this is really important for our patients. And again, dead vaccine, safe to get even when they're on their medications.
Absolutely. And I love the trick, lay for the lower number first, because I always get confused which one is first. So now I know what to do. Thank you for that. All right. So now we're going to shift gear and talk about COVID-19 vaccinations and the importance of it in everyone, including our patients with IBD, whether they are or not on immunosuppressive therapy. So Meena, the first thing that people ask is the vaccine safe, and is it effective in patients with IBD, especially those that are on immunosuppressive therapy? And are there any subpopulation of IBD patients that could are at high risk of mounting less of a response to the vaccine?
These are top of mind questions. And unfortunately, we maybe had this glimmer of hope that we were going to not have to talk so much about them about 6 months ago, but now it seems like we're in for the long haul here. And whenever I talk about COVID vaccines, I really think it's important to put this into the scope of the actual risk of getting COVID. All right. And just to remind folks, beat over the head with this, it's all over the news, but we're on track to have 1 million people dead in the United States alone from COVID. We're on track to have over 150,000 children who have lost a primary caregiver or guardian. And increasingly in the United States, this is affecting the folks who are getting hospitalized are a younger population. These are under the age of 40 and our children. And so anyone who can get these vaccines should get vaccinated. So the question, like you said, is, first of all, let's talk about effectiveness. Do these vaccines work if I have IBD or if I'm on the medications for IBD? And I'm going to insert a disclaimer here. When we discuss vaccine effectiveness, we are often talking about maybe an antibody level or something like that. A very, very strong reminder, the CDC, the FDA, and the Infectious Disease Society of America all strongly recommend against checking COVID-19 antibody levels. These are for research studies only. They're not standardized, they're not validated, they're not comparable. And if you ever talk to an immunologist, they will give you a long lecture about how your immune system is more than an antibody level. So, but what do we know? And then also just a reminder that IBD is not rheumatology or dermatology or oncology. And at the beginning of the pandemic, we really relied on our partners on other diseases to give us information, but we have great studies now that are IBD specific, and they can tell us that these vaccines work really well in our IBD patients. In fact, our IBD patients respond to these vaccines very comparably to the general population. So the CORAL study was a study from Cedars-Sinai. It looked over 350 patients. The majority were on immunosuppression. Nearly 100% of them got an mRNA vaccine, so a Pfizer or a Moderna vaccine, and all of these patients got an effective antibody response. Icarus study from Mount Sinai is a little smaller, about 50 patients, but again, same robust response to the general population. And then the study I like to talk about is Prevent COVID. This is headed by Dr. Michael Kappelman and Dr. Millie Long at UNC. And in full disclosure, I'm a site PI at Penn for this. They have over 3,500 people from across the country who have inflammatory bowel disease who participated. Maybe patients who listen to this may have participated. Thank you very much. Over 90% of these patients were taking some kind of medication, majority are on immunosuppression. Over 95% got an mRNA vaccine. And of those patients who got an mRNA vaccine, they had a good antibody response that was comparable to the general population. Risk factors for not responding: age and time since you got your vaccine. Those were associated with lower antibody levels. We know that the general population. Older population, they don't respond as well. You had your vaccine a long time ago, your antibody level is going to wane a little bit. Getting 2 doses of mRNA versus 1 dose of J&J, the 2 doses of mRNA had a bit stronger response. And this I think is the most important for our providers and our patients, combination immunosuppression. So not just a biologic, but being on a biologic plus thiopurine like azathioprine or methotrexate. Everybody else had the same comparable response to these vaccines you would expect from the general population. So the good news for our IBD patients, you're responding to these vaccines like the general population. You should take a great deal of comfort in that and comfort in knowing that it's working. Now, what about safety? Listen, over 7 billion people have gotten a dose of a COVID vaccine worldwide. That is the largest real-world study of any drug I've ever had the privilege of watching in real time. And we know that in the history of vaccines, going back to the smallpox vaccine, all serious side effects occur in the first 6 weeks after a vaccine. And the first dose of an mRNA vaccine was in March of 2020. So we are about 2 years of data and billions of people. They are safe. And the good news for IBD patients, they're effective for our IBD patients as well.
This is all good news in a time where we're struggling, longer and longer with COVID. That's why we're not having this conversation face to face, and I'm not hugging you when I see you. But it is amazing news that we have an effective vaccine, including for our patients with IBD, including those on immunosuppressive therapy, and that is safe, even if you're on immunosuppressive therapy.
Absolutely.
This is the best news we can have. Absolutely.
And it's safe in our vulnerable populations too. And I think about 2 particularly vulnerable populations. Children, please, if you have a child, even if they have inflammatory bowel disease, 5 years or older, get them vaccinated. This is so, so, so important. And also in our pregnant women. And in pregnant women who get COVID and are symptoms from COVID, they have a 70% increased mortality from that, which is just devastating. And it's not just the morbidity, the mortality, but also the morbidity for these women, that they and the morbidity to the unborn baby, including preterm birth and stillbirth and NICU stays. Multiple studies, not just the United States, but internationally, showing these vaccines are safe. And that they confer antibodies to the unborn baby as well as to a mother who's breastfeeding and the breast milk. And so we really, really recommend that women please get vaccinated if they're thinking about having a child or if they're pregnant. Unfortunately, in the United States, only about 1/3 of pregnant women are vaccinated against COVID, and we really need to change that.
And I'm glad you pointed out how pregnant women and infants are actually at higher risk of mortality and morbidity from COVID. And typically we recommend vaccination in pregnant women later in pregnancy, but COVID, we want it early on so that you can pass on the antibodies to the baby, because we can't vaccinate babies yet.
Yes, parents of kids under the age of 5 are still struggling, and it's a real problem. And having just had a child who could finally get vaccinated because she was 6, the struggle is real. I appreciate that struggle with the kids who can't.
Absolutely. My daughter was so excited when she was able to get her as my son. So I've never seen them excited to get a shot like this.
Never before.
They were screaming with the flu, but the COVID vaccine, she was up for it. So yes, absolutely, our pregnant women. You talked about maybe a decrease in efficacy of the vaccine in older patient on combination therapy. How about patient on steroids? I get this question a lot. If you're on a high dose prednisone, should you wait until your prednisone dose is lower or off until you get your vaccine or your next dose, etc.? What do you practice?
This is tough, and I think that this is there's no official recommendation because you're kind of caught in a risk situation here. Yes, higher dose steroids have been associated with a decreased response to vaccines. Does that mean that it's still not enough to protect you, or that it isn't going to fire up the rest of your immune system to protect you against COVID? We don't know that with the COVID vaccines. On the flip side, we know that there's a lot of COVID out there. And what you wouldn't want, for example, is a patient who's at 30 milligrams of prednisone, for example, and then gets COVID because you were trying to wait to get them vaccinated until they got to lower than 20 milligrams. So I think this is a conversation to have with a patient, because if the patient can really stay at home and have no exposures and can hunker down and everyone around them can hunker down, maybe yes, that's a situation where you could try to wait until they're a little bit lower on their dose of prednisone. But most of my patients work, they have kids, they've got a family member who's working, and that's just not possible. And with so much COVID, I think sometimes you say, look, let's get you that first dose or whatever it is, and let's try and get you off of your prednisone. And at the same time, then we can get you your second dose or your booster as well. But you just don't want them to be unprotected because the worst outcomes we've seen are with people who are unvaccinated.
I absolutely agree. Absolutely agree. So now, we got our 2 doses of vaccine, and the recommendation was, let's get a third one because it sounds like the immunity decreased after 5 to 6 months. And it seemed that the recommendation have changed from get the third dose at 6 months to as early as 5 months. But the one thing that I struggled with, Meena, and please, explain it to me. Is there a difference, because we hear those 2 terms and I know they're not interchangeable. Is there a difference between a third extra dose and a booster dose? And who needs an extra dose or who needs a booster?
It's confusing, and people using them interchangeably, and there is actually a difference between them. So I like to think of it as getting to a top of a hill or a mountain, and it's snowing here when we're doing this right now. So top of a snowy hill. And for the majority of folks, you needed 2 doses of the vaccine to get to the top of the hill. But for some folks, and this is what a third dose is, for whatever reason, you didn't get to the top of the hill with just 2 doses. And we were seeing this in our severely immunosuppressed patients. What do I mean by severely immunosuppressed? Patients who were on cancer therapy, like chemotherapy, patients who had organ transplantation, and in our IBD patients, it appears maybe those patients were on combination immunosuppression. So you needed a third dose to get to the same place that everybody else just needed 2 doses. So that's the extra dose. A booster is when you got to the top of the hill with your 2 doses, everything was fine. But over time, there's normal decreasing of the vaccine. You're on your sled and you start going down the hill a little bit. It's just starting going down. The longer you wait, the faster you're going to go, the lower you're going to go down the hill. And so that's for everybody, then you need that booster. And the boosters have been recommended, as you said, until recently, 6 months after you completed the primary series. Primary series being 2 doses for most people, maybe 3 doses, that extra dose for patients who are really immunosuppressed. But now the booster is 5 months after you've completed that primary series and it's recommended for everyone, including now we've lowered the age group even for those down to some of our children 12 years and older to get that booster dose. The reason is just that we have this new variant. This variant has a lot of mutations. It is able to deal with our vaccines a little bit more efficiently than other variants and the original SARS-CoV-2, and we just need to have a little bit more of that vaccine around to help protect us. Now, there is this 4th dose discussion. Um, and so, what is a fourth dose? Well, if you were somebody who needed 3 doses to get to the top of the hill, your booster is now your 4th dose. That should be 5 months after, you've completed your primary series. If you have reached the booster series right now, there's currently no official recommendations for a 4th dose, but there is data from Israel and elsewhere that in light of Omicron, I think they're having their healthcare workers and their elderly population get this 4th dose because they are 4 or 5 months out from their booster. And there's waning of that booster. And with Omicron and all of its mutations, maybe we need to get ourselves back up the hill, boost ourselves back up the hill a little bit. We don't have an official recommendation, but stay in this space. We're learning all the time here and stuff is changing quickly.
Well, thank you so much. First of all, I love the hill comparison. Now I get it. I understand it. It's wonderful. I'm going to be able to use that with my patient. And I think what you said is very true, that this is a moving target, right? So we're learning. And I think it's very important for everyone to realize that it's not that we don't know what we're doing, it's that things are changing and we're adapting and we're learning and we're taking the appropriate measures. So the vaccine is working. It's preventing people from being in the hospital. Even if you get COVID, you're not on an incubator. And the fact that we need another dose and another dose doesn't mean it's not working. It means it's working. We just need some kind of maintenance because viruses keep changing on us and we need to update our immune system in some way.
I love that term maintenance because it is true. This virus is mutating and the vaccines still work. And there's a lot of real world data now that with the vaccines, no vaccine is 100% prevents you from getting anything. I like to think of it as the umbrella like analogy. When you go out in the rain and it's a light rain, you can just use your umbrella, your vaccine, and it's going to protect you. You might get a little bit wet, but you probably wouldn't even notice what's going on. But if it is a full-on rainstorm, lightning and thunder and gusting wind, you're not just going to go out with an umbrella. It's not going to work. You're going to need to wear a raincoat. And this is when we say, okay, I've got my vaccine, but I'm going to wear my mask as well to really prevent myself from getting, or being exposed or exposing others. The vaccines still, however, minimize the impact of this virus and they minimize you from getting severely sick. And that's what we're seeing. We're seeing a shorter duration of feeling symptoms if you get a breakthrough infection, and we're seeing less severity of those symptoms. And that can mean all the world for patients, especially patients who may have an underlying condition. The difference between being hospitalized and dying and just having a really nasty cold for a couple of days.
Absolutely. And I could talk to you forever. I never thought that vaccine conversation would be so fascinating. But before I let you go, Meena, I have one more questions for you because this comes up often in clinic. And as you mentioned, most of the study looked at the efficacy of the vaccine with mRNA. What about our patient who got a J&J vaccine? And in other part of the world, people who got the AstraZeneca vaccine, so non-mRNA vaccine, what would be the recommendation? What should they do? Can we mix and match?
Yes.
And what schedule should they follow moving forward?
So this is a really good question. There's some people who didn't want to get an mRNA or couldn't get an mRNA for whatever reasons and needed to get a J&J or did get a J&J. And I think the good news, the first couple of good news, first of all, the J&J needs 2 doses, but with 2 doses, it gets above 90%. So it's very similar to the mRNA vaccines. And what the studies did also show is that it doesn't have the same kind of waning effect that we're seeing with the mRNAs, or not as much. And so that's also, so if you're someone who got J&J vaccine, it's not that you got a subpar vaccine. I don't want folks to sort of think of it that way. Just you do need to have at least that 2nd dose. However, the recommendation from the CDC about following up with an mRNA if you needed to get a booster and have that option was not based necessarily on the efficacy, but more on the safety. Because with the J&J and the AstraZeneca, there is this association. Very, very rarely you'd have to treat 1 million people to get like 3 cases of these clots that could be life-threatening. And you don't have that side effect with the mRNA. So all other things being equal, the mRNA is considered to be safer. And that was why preference was made on that. Now, I get a lot of questions about people about mix and match. Should I be mixing and matching, and is it better? The mix and match studies, which were done at the NIH, and they were just fantastic studies, were not meant to show that anything is better. They were meant to show that they work, that if you got an mRNA and had to get a different mRNA, if you got a J&J and you got an mRNA secondly, like for your booster, that you still mounted as robust a response to these vaccines as if you stayed in your series. And I think it's also important to understand these were 40 people in each arm, and they excluded patients with underlying conditions. They excluded patients who are on immunosuppression. They excluded older patients. Okay, so don't, if you hear that, oh, they did this and everyone's saying you should do this, that may not necessarily apply to you. The way I use it is if a patient of mine lives in an area and they can't get a booster with Pfizer, and they got their first 2 doses with Pfizer, but they can get a booster with Moderna, go get Moderna. It's going to work, and it's going to work fine. If you feel comfortable with Pfizer and that's what you got and you have the ability to get it, go ahead and get it. You're going to have a similar response to everyone else. So there's, mixing and matching is effective. It's safe. There's nothing that's better. And I think that's the most important message to get out to folks.
Absolutely, and that's very helpful. I had to mix and match just because this was what was available.
Yeah.
Any vaccine that you have, I'll take it.
That's it.
This is not the time to have a designer vaccine. I want whatever you have on the shelf. I'll take it.
The best vaccine is the one in your arm. That is without question, and especially right now, the best vaccine that you can get.
Meena, it was such a pleasure. Your knowledge is just phenomenal, and I really enjoyed this conversation today. So thank you so much. I know everybody benefited and learned like I learned today from you. So I really appreciate your time.
I love talking to you. I could talk to you forever, Aline. I just wish we could be in person because I miss you guys. I miss my colleagues. We will get through this. We're incredibly lucky to have incredible doctors like yourself who are organizing this and efforting these communications and all of this education, even when we can't be in person to do this. Thank
Absolutely
you.
Appreciate those words. Thank you, Meena. And for all of you who tuned in our brunch, thank you for joining us. Don't forget to check out our tutorial tomorrow under Monday Night IBD that will complement the discussion we had today with Dr. Bewtra. Please make sure to claim your CME credits by completing the post-test and evaluation from the link above. And we'll have additional brunch events focused on health maintenance in IBD next week and then again in March. Thank you so much for joining us.